coming in locally advanced or metastatic disease, having a good screening protocol may probably help reduce this. But the trend that we are going, if we don't really put in any measures, we are likely going to meet this 9,300 cases in the next 10 years. And when it comes to the mortality, currently we about 2,370 patients dies out of breast cancer annually. And by the next 10 years, the mortality rate is expected to rise by 87.7%. So we are expecting about 4,450 patients to die annually from breast cancer. So to do this means we have to diagnose early, put in effective measures to manage patients so that we'll be able to reduce the mortality of breast cancer. So I put out this question like, is Ghana, are we really ready for the increasing rise in incidence and mortality of breast cancer? There's one thing that we need to think about as we go along. And to me, I think there is a yes and no situation. I'll go for no in the fact that we have limited available or essential cancer service. Even though to a certain extent, breast cancer is covered under national health insurance, the diagnostic process is not under insurance. And that's where most patients are likely going to default and seek for alternative treatment. So we don't have mammogram on insurance, we don't have pathology service on insurance. And even if you look at radiotherapy center, for the past 27 years that radiotherapy came to Ghana, we just have 2 public centers. And out of that 2 public centers, the resources have not really improved to meet the country's needs. And always there is a malfunction of machines and everything that tends to affect the treatment management. So that's one thing that makes it a little bit difficult for us. The other thing is poor accessibility to cancer management. Because we have 2 centers, one in Accra, one in the Kumasi, patients around the country always have to travel just to go and seek treatment. So if you don't have any relative within that period, that place, or probably you can't afford extra accommodation, it's going to be difficult for you. So most patients are likely going to default because of that. And we are having, even though as I mentioned, insurance covers to a certain extent, everything is out of pockets. So if you don't have money or your relative don't have money to cater for your cancer care, you are not likely going to continue. And with the increase in the stability of the dollar, mostly the prices of goods keeps on going high. So always you go and ask for a drug today, the following day the prices is a little bit high. And since cancer services came to Ghana, most people have dedicated their lives to it. We have a lot of nurses or pharmacists, medical physicists who actually started and had good grasp of it. But because they are not paid well, most of them are now moving out of the country. So we are losing our skilled oncology services. And I'll think about is yes, because even though we have limitation, we have kept, we have been on the path. We've not deviated much from the path because in some countries they started oncology services and along the line there's nothing for them to boost about. But at least we tend to have oncology service running day in and day out. And with now we are expanding our human resources because in the past you just have maybe 1 or 2 oncologists, clinical oncologists managing breast cancer. Every other person will be maybe a normal, not normal, let me put it, like a pharmacist without an oncology background or a nurse without an oncology background. But now even the clinical oncologists are increasing. The oncology pharmacists are increasing. The clinical, the nurse oncologists are also increasing. So this gives patients more expertise, expert being manage their treatment to improve their survival. And with continued professional development such as this, we always keep abreast with what exactly is going on. So it makes it easy for us to know what the standard is and how best we'll be able to give our patient the standard. And there's a lot of public-private partnerships, even though some of them may not be formal, but at least all the private organization that comes, they understand the need of the public institutions. So just like maybe AstraZeneca is organizing these programs, it's because of the need. They probably know that, okay, the people need. And they are doing a lot of access programs also just to be able to help patients purchase medication. And there's also growing awareness of early awareness and early detection of breast cancer. Every October, we have Pink October. Even though it have not really, to me, it have not really met its targets, but at least to a lot of people, Pink October drives something into their brain. So it let them know that, okay, there is a lot to do, or there's something called breast cancer, which they may probably have to examine themselves for. So we take a quick look at the pathophysiology of breast cancer. If we to understand the pathophysiology, the first thing we need to do is to understand the normal breast. The breast is made up of what we call lobules, and it connects to duct. The duct is what connects to the nipple for a child to suckle. So we have a lot of lobules, and there is a duct. Majority of time, breast cancer tends to occur at the intersection where the lobules meet with the duct. So because mostly where there are two joints, it tends to be a little bit unstable. So any mutation can cause cancer to occur. And if you take the lobule, we have what we call uh, a duct epithelial, or what forms the inside of the duct. And outside, we have what we call the basement membrane. What the basement membrane does is try to limit everything within the particular duct. So that becomes the natural border of the that tissue. So for breast cancer to develop, sometimes it may once there is any mutation, it causes the cancer cells to undergo a lot of abnormal growth. And this abnormal growth, when it happens and the basement membrane is intact, that's what we call something we may refer to as carcinoma in situ. Because even though they are cancer, it's well contained. So they've not really taken the characteristics of a pure cancer cells. But once it breaches its barrier or its basement membrane, that's where we have invasive carcinoma. So when invasive carcinoma, once it starts moving, it has a probability of coming in contact with blood vessels and going through something what we call intravasation. Like it tries to get into the blood vessels, and once it's in the blood, it has the probability to move to any part of the body and become a metastatic disease. And sometimes when it gets in the blood, one thing that makes it difficult for or make it easy for them to travel is the fact that they transform how they look, because mostly cancer or breast cancer develop from epithelial cells, and epithelial cells are relatively fast growing. But when they get into the blood, sometimes they can convert to what we call mesenchymal cells. So there is something called epithelial mesenchymal transformation. That's the EMT. And mesenchymal cells are difficult. They take a longer time for them to grow. So just like, let's say, your muscle, your bone, it gets to a certain point, it doesn't grow as it's supposed to be. So that's how breast cancer tends to occur. So if you want we want to take a deeper look at how the cells look like, and look at the membrane, or whether it is a lobule or the duct. We tend to have different type of cells within that lobules and the ducts. So apart from the basement membrane, we have what we call basal cells. Basal cells are what actually contracts for the milk, or if there's any milk in that particular lobule, for it to move. Or probably if it's within the duct, it helps with the contraction for it to move in a particular direction. And inside the lumen. The lumen has what we call the estrogen and progesterone receptors. Those are what is stimulated for the breast milk to be produced. So mostly if we have mutation taking place in the lumen and cancer develop in the lumen, we are likely going to have what we call luminal cancers. And those are mostly associated with estrogen receptors. They are going to be estrogen receptor positive. But if you're having cancer that are coming from the basal cells, that actually is supposed to contract and doesn't have estrogen receptors. And those are what we are going to call basal carcinomas. And these are estrogen receptor and progesterone receptor negative. And the basal cancers are what normally forms the like tumors. So, mostly if we come to the clinical setting, mostly patients who are triple negative, they are likely going to be asked to do a BRCA test because majority of the time they're triple negative at the basal cells, and likely we will note that BRCA may play a role in their cancer development. So we are doing the test now. There are medication to target BRCA, so that to be able to treat with that medications. If you look at the cancer biology of breast cancer, as I mentioned, we tend to have what we call inside to carcinoma. So majority of the time, we tend to have negative breast cancer. So for now, these are the major cause of breast or major subtypes of breast cancer that we have, but there are ongoing research to modify some of them. And why is the need for you to know the subtype of breast cancer? As mentioned, breast cancer is not the same. So knowing the subtypes helps you to improve or personalize the treatment to the patient, because you are in the era of personalized medicine. And in the era of personalized medicine, you always want to make sure that depending on what features the patient have is that treatment you give to the patient. And that tends to reduce over treatment and under treatment, because sometimes we may probably give patients some treatment, you are going to have side effects which may not be beneficial to them. So to prevent this, that's why we need to personalize the treatment just to help them. And there are always ongoing trials to try and refine these classifications. So if you look at the histological biology of most of the breast cancer, as I mentioned, we tend to have what we call in situ carcinomas. In situ carcinomas are mostly pre-invasive carcinomas. They have not been broken through their basement membrane. And this statistics is actually from developed world. So because they are doing a lot of screening and mammogram at an early stage, they're able to diagnose about 25% of their population with pre-invasive carcinomas. But in Ghana, I can say less than 2% of our patients actually present with pre-invasive carcinomas. Majority of almost 99%, 98 to 99% of our patients have invasive carcinoma. And the histological type, we tend to have the ductal carcinoma and lobular carcinoma. So you're likely to hear something called ductal carcinoma in situ or lobular carcinoma in situ. And also you may have invasive ductal carcinoma. Now, we don't normally use the invasive ductal carcinoma. You may meet that invasive carcinoma, no special type. And we also have invasive lobular carcinoma. The main reason we tend to distinct these two is not just the fact that, okay, maybe we just want to know where they are coming from, because their behavior is a little bit different. With lobular carcinoma in situ, as you mentioned, the lobule is it's a tube, okay, and it's a little bit fibrous. So majority of the time with almost all lobular carcinoma in situ, even if you don't see them on mammogram, you can easily palpate them. But with the lobular carcinomas, the lobe is a little bit, it contains breast milk, so it can easily stretch. So because of the way it stretches, if cancer is developing, they have a lot of space for it to move. So it's not always that you'll be able to palpate a lobular carcinoma, even if it's big. Sometimes you can feel an ill-defined area, but you may not be able to see any lesion in it. And one thing about the lobular carcinoma is the fact that sometimes they can undergo what we call mammographically silent, become mammographically silent. You do a mammogram, you're not going to see any tumor cells in that patient. So in that case, mostly if you examine and you probably see that a place is ill-defined, or you can feel some lump, irrespective of what you are seeing, it's best you do an image or do a guided biopsy just to confirm whether whatever you are seeing is a lobular carcinoma or not. When it comes to the molecular subtype, the first one we have is the luminal A cancers. And the luminal A cancers are mostly estrogen receptor positive strongly, and they may or may not express progesterone receptors, but they always are HER2 negative, and the Ki67 is always less than 14%. Ki67 is what we call proliferative index. It just gives you an idea about how fast the cancer is going. So if I have a higher Ki67, it means that the cancer is rapidly growing. So it's easier for you to target it with like chemotherapy. But if it's less than 14%, it means that it's slow growing. So most of the time with luminal A, cancers may probably be well differentiated. And it's the most common subtype of breast cancer in the world. It's because it's slow growing, it tends to have a best prognosis and respond well to hormonal therapy. And this patient doesn't require chemotherapy. And now, because of improvement in hormonal therapies in our environment, first we just have aromatase inhibitors and tamoxifen. But now at least we are able to have other hormonal therapies. We are having the fulvestrant, the other anti-estrogen therapies, the fulvestrant. We have also have the goserelin, which can also be used even alongside some of the old therapies. So we are improving cancer care just based on these. So mostly when it comes to the luminal A, majority of them may not require chemotherapy. Just a few of them may require chemotherapy. And advancements in medicine have let us know that to help you identify which patients you are going to give chemotherapy. Now there's something called molecular profiling where we do oncotype DX or mama print. What it does is to be able to tell the risk at which patient is likely going to recur. So if you do them, and they are using gene sequencing. So like Oncotype use 21 genes, and so if the 21 genes, they do the sequencing of those 21 genes, and maybe the mutation is a little bit higher. They can give you a score that maybe the risk of recurrence is a little bit higher in this patient. So because it's high, give the patient chemotherapy. So these are what we use to guide us in making decisions. When you look at luminal B tends to have two subtypes. The first subtype is just like luminal A, but just that they tend to have a high Ki67. So their proliferative index tends to be a little bit high. And the second subtype is the one we call triple positive. Both the estrogen, the progesterone, and the HER2 receptors are all positive. So just to help you, or maybe I think a slide that I wasn't able to insert. Majority of the time when a patient gets a biopsy done, the biopsy tends to give us two results. One being the histopathology, and the histopathology will be what will confirm is it breast cancer or not. So in this case, as we mentioned, we went back, the histopathology will let us know if you are dealing with maybe an ductal carcinoma in situ, invasive carcinoma, invasive ductal carcinoma, lobular carcinoma, or invasive lobular carcinoma. So that's what the invasive cancer tells you. Just give you the broad cancer that you are dealing with. But the second report that you get is what we call immunohistochemistry. The immunohistochemistry tend to test for three things: the estrogen receptor, the progesterone receptor, and the HER2 receptor. So for luminal B and the Ki67, almost all in immunohistochemistry is supposed to come with the Ki67. So if your estrogen receptor is positive and progesterone receptor is either positive or negative, but HER2 is negative, then Ki67 is more than 14%. This was when we define it as a luminal B disease. So it can be an invasive carcinoma, no special type, but it's classified as a luminal B. And we can have invasive lobular carcinoma, no special, then we can still classify it as a luminal B. When the estrogen receptor, progesterone receptor, and the HER2 receptors are all positive, that's what we become triple positive. And with triple positive, at least they behave similar to this type of group of patients. So that's why we put them together. And comparing them, because their proliferative index is a little bit higher, they are more aggressive than luminal A. And based on that, their prognosis tends to be worse compared to luminal A. So for these patients, they are more likely going to be treated with hormonal therapy, because as mentioned, all of them at least they will have estrogen receptor or progesterone receptor expression. So they are going to be treated with hormonal therapy. But because their proliferative index tends to be high, they are going to receive chemotherapy. Unless there is a contraindication for chemotherapy, all luminal A patients tend to receive chemotherapy. And for HER2, a patient who may be expressing HER2 as the second subtype, if the HER2 is positive, that's why we give HER2 targeted therapies. So the third group is what we call the HER2 rich. They tend to have the estrogen receptor and progesterone receptors being negative, but the HER2 expression is strong, and the HER2 expression can be, majority of the time, if you do the HER2 on the immunohistochemistry, it can be reported as either being 2+, either being 0, +1, +2, or +3. If it's +3, that's when it's more is positive on immunohistochemistry. But in case you do it and it's +2, then that means equivocals. Not either if +1 and 0 are negative, or some +1 now they are going out as a HER2 low. Okay, but when it's a +2, then that means you have to do what we call a FISH, fluorescent in situ hybridization, just to be able to see whether there's amplification. For the application, then becomes a positive. So mostly for HER2 rich, there are estrogen receptor, progesterone receptors, and HER2 receptors positive, and they are rapidly growing. So their proliferative rate also always tend to be a little bit high. Previously, it was associated with poor prognosis because of the rate at which it was growing, and we had nothing to target the HER2. By the advent of anti-HER2, we are having a better survival with these patients. And these patients tend to be this disease tends to be common in younger women, and mostly majority of the HER2, if they are HER2 rich, may receive chemotherapy in the setting of even if it's palliative or curative intent, because the chemotherapy tends to help out with the survival outcome. The last group of patients are what we call the triple negative breast cancer. And that's the type of breast cancer majority of the time a lot of people don't want to get because it tends to have a bad prognosis. These patients tend to present with estrogen receptor being negative, progesterone receptor being negative, and HER2 also being negative. And most of them are from the basal cells, so they are basal-like carcinoma, and they have a high proliferative and genetic instability. As I mentioned, majority of them may have BRCA mutation, and BRCA tends to cause a lot of instability in cancer cells. So they are very aggressive, and it tends to be common in younger African women, because if you go to the literature will tell you that in advanced countries, about 15%. But in Ghana, most of the studies have shown that it's up about almost 30% of our patients present with triple negative breast cancer. And in some parts of Africa, they have reported as high as 50% of their population. So triple negative tend to be one of the aggressive diseases, and it's quite common in young and black women. So patients with triple negative tend to have a higher risk of recurrence within the first 3 years of treatment. And because we don't have a lot of targeted therapy, chemotherapy is the mainstay of treatment for patients with triple negative breast cancer. But in recent times, the advancements in medicine have let us know that the triple negative patient tends to also express PD-L1. PD-L1 plays a very important role in our immune system, and BRCA also, which is also essential for homologous recombination DNA repairs. So mostly with patient that has PD-L1 or BRCA, if it's in metastatic setting, even with PD-L1 now it's being introduced in the curative setting. So mostly if patients have PD-L1, you can actually add immunotherapy to their treatment, and they tend to do well. But if it's in metastatic setting, sometimes can introduce BRCA, medication for BRCA. And as I mentioned now, some triple negative tends to have different subtypes. We have what we call the mesenchymal, the basal-like. Then we have the androgen receptor positive triple negative receptors. So now, at least in some of the triple negative receptor, there has been studies ongoing to see whether, because some of them may express androgen receptor, we can actually treat them with bicalutamide to see whether they will have a better survival. Each histological subtype or molecular subtype tend to behave differently, even in terms of in clinical presentation, because when you take the invasive ductal carcinoma or invasive carcinoma, no special time, they spread or metastasize to the bone most often. So majority of the time, the invasive ductal carcinoma normally presents with bone mets compared to lobular carcinoma, and invasive ductal carcinoma can go to the lung, the liver, and the brain. But when it comes to the invasive lobular carcinoma, they are a little bit tricky. They don't always have the typical metastatic side that you'd be expecting than the bone, lung, liver, and brain. They can present or go to the GI tract and present like maybe a GI malignancy. So if you don't take care, you think that the patient has a second cancer, but maybe it may be metastasis from the breast that's gone to the GI tract. They can go to the peritoneum, the ovaries. So sometimes you think a patient is having ovarian CA because the patient has a history of breast cancer, but maybe it will be spread to the ovaries. And it can go to the uterus and to some extent to the bone. if you look at the molecular subtype, triple negative tend to go to every part of the body, but less frequently to the bone. So it can go to the liver, the brain, and the lung, but less frequently to the bone. The HER2 receptor, HER2 positive breast cancer normally spread to the brain because the brain also has HER2 receptors. So once there is any cancer and the cancer is moving across, and once it gets to the receptor, if it sees like it's at home, so it can easily go to the brain and mostly for HER2, and can go to the liver, lung, and bone. If you take the hormone receptor positive cancers, they normally spread to the bone because remember, if you are supposed to go back to like let's say histology or anatomy, you know that the bone also has a little bit of estrogen receptors because of the bone remodeling. So it's one of the places you may frequently see cancer cells being spread to, and it can spread to the liver, lung, and less commonly to the lung. So apart from the way that they spread, each subtype and how or they recur, all of them, the fact that you have a disease, all of them you are at risk of recurrence, but the pattern of recurrence tends to differ from one subtype to the other. So if we take the luminal breast cancer or the hormone receptor breast cancer, the rate of recurrence tend to be low. But through the person's whole life, the persons have a higher risk of recurrence because even though it's not really high, it's a little bit stable. So no matter each point in your life after treatment, you are at a higher risk of recurrence. And these studies were mostly done when we didn't have the newer medications. So I'm hoping that with times, once we start using some of the new medication, maybe the pattern may be a little bit different. But if you look at something like the HER2 tends to recur mostly within the first 3 years of treatment. So it will recur rapidly. Then by the 4 to 5 years, it falls down. Then after 5 years, there'll be a second peak of recurrence. By after 7 years, mostly how do you HER2 receptor or patient recur? So you're comparing to luminal or hormone receptors, even though the recurrence is a little bit stable, it's throughout your whole life. But with HER2, after a certain years, the risk of recurrence is negligible. Likewise, triple negative also have similar pattern. The recurrence is very high within the first 3 years, then it start dropping. And by 8 to 9 years, sometimes there will be no patient that will be recurring, or if the recurrence will occur, they are very few. So we'll go through staging. The staging has gone through a lot of processes, and that's a lot of this. What we've got into is based on theories that were developed over the period of time. In the late 80s, Hostad proposed that mostly cancer move in what we call an orderly fashion. It moved from and that's why a majority of these studies were in relation to breast. So it moved from the breast. Once it becomes bigger, it gets to the lymph nodes. Then from the lymph node, it gets to the systemic or the blood vessels and goes to other parts of your body. So with his theory, cancer is moving in a uniform pattern. So during the period of Hostad, at that time, there was not a lot of systemic therapy. So they did a lot of what we call aggressive surgery. So they did what we call radical mastectomy. And the radical mastectomy, you remove the whole breast, you remove the chest wall muscles, some of them. Then you are going to dissect the axilla from level 1 to level 3. Level 3 tends to be just beneath your clavicle. So just imagine putting your hands into your axilla, trying to get into your clavicle. You are going to cause a lot of damage to yourself. So those surgeries were associated with a lot of morbidities. But because that time we didn't have anything to go for, we accepted it and those surgeries were done. But with time, Fisher came and Fisher noticed that even though we are doing those extensive surgery, patients were still recurring. So Fisher started doing studying patients' blood, and that's one of the fundamentals of the how to call it case control studies. Okay, so Fisher noticed that if you take a patient with a breast cancer, no matter how small the breast cancer may be, you can see some cancer cells in the blood. So Fisher proposed that cancer is not localized or doesn't move in that localized fashion. That's a Hostad thought. But cancer actually is a systemic disease. So even if after going through the surgery or probably having, at that time, systemic therapy, chemotherapy have been introduced, or having some kind of chemotherapy, there's still some cancer cells in your body. In simple terms, the fact that you don't have recurrence or you don't have metastatic disease doesn't clear you of cancer. So that's what Fisher proposed. So based on that proposal, at least the extent of surgery was a little bit reduced. So that's when we started getting the radical mastectomy, the modified radical mastectomy being done, where we just take the breast tissue and do level 1 and level 2 axillary lymph node dissection. But over the years, Hellman also came and noticed that at least if you follow patients that have localized disease, not all of them will have recurred over a period of time. So he brought in what we call the spectrum theory, just saying that the breast cancer presentation is just like you being on a spectrum from 0 to, let's say, 10. 0 means you can recur. 10 means when 0 means you are not going to recur. 10 is you are likely going to have a metastatic disease. So you are going to have different patients coming in with different clinical presentation in terms of breast cancer and their management. So even though you may see some cancer cells in the blood, it doesn't mean that the cancer cells has established itself. So in so doing, they can easily be treated or cured if they're giving systemic therapy. So based on this, he tried to propose that cancer, because it's on a spectrum, you can sometimes have patients with local disease, locally advanced disease, metastatic disease, and in the metastatic disease, you can even have patients with oligometastatic disease. That means the patient may probably have cancer cells that have established somewhere else, but it have not fully developed, or probably they are limited. So because they are limited, you can actually treat the cancer that's have gone to like let's say the lung. Let me use a patient for example. I had a patient I treated for breast cancer, hormonal receptor positive. 2 years on tamoxifen, she came in with a lung lesion. So, and it was a solitary lung lesion. Because it was single lung lesion, we weren't quite sure whether it's a second primary, a lung cancer, or the metastatic disease. So we referred her to the cardiothoracic surgeon, and they did a lobectomy. It came out as metastatic disease, and we started patient on aromatase inhibitors. 5 years down the line, I think the last PET scan that the patient did, it shows a little bit activity in the lung, but it's not really intense. So this patient, because we took majority of the cancer cell and metastatic disease out, the patient has been able to live 5 years without any issue. But I have patients who have presented with similar pattern, but they didn't go in for surgery, and they were started on maybe aromatase inhibitors, and they recur shortly after, maybe about 2 or 3 years, they are going to recur, and maybe even have more disease or progress with more lung lesions. So that's what Hellman was trying to say, that if you're able to identify patients who have localized disease, oligometastasis, sometimes you can actually treat the oligometastasis and patient will do well. And in the era of improved radiation therapy, like SBRT, stereotactic radiation therapy, sometimes you can even give high radiation dose to those places, and you'll be able to control the cancer cells, and patient tends to do much better. So what's the importance of staging? Staging help us or guide us in our treatment planning and decision making, because each patient and how you are going to manage them. In the patients, if depend on the stage, whether it's a stage 1, stage 2, we can classify them as maybe locally a local disease, or probably locally advanced disease. So that's also going to help you to know how to go about with your treatment management. Based on staging, you can determine which patients are going to do well and which patients are not going to do well, which is also very good when you are counseling patients, because the counseling patient is not going to take this medication. You have to let them know their life expectancy, or have a fair idea about the state that they came, so that they will have their own expectations. Because if you go and tell patient that, okay, oh, the disease is curable, yeah, it's curable. But if after 5 years the person is coming in with recurring disease, the patient may be a little bit disappointed. But if you let you know that, okay, you have a localized disease, it's curable, but the risk of recurrence is about 20%. The patient always knows that there's a high probability of recurring. And using staging, we are able to communicate with each other, because if I have a lesion and I say somebody should, maybe how I want to communicate with the person, going to tell that, okay, I have a breast with a 6x6 ulcer fixed to the chest wall, have A, have B, have C. It may not be or very clear to the person, because until you see it, it becomes clearer to you. But if I tell somebody that, okay, I have a T4B or T4C lesion, the person knows what exactly they are anticipating, or you are talking about. And it also helps us to compare outcomes across institution, because if I'm going to do a study in Kolebu Teaching Hospital and I want to compare to a study in Konfanochi Teaching Hospital, the stage will be one of the major things that I'll use to be able to determine how each stage tends to fare. So when it comes to staging, we tend to have the what we call the TNM staging. The T being tumor, M being node, and M being metastasis. The TNM staging are mostly used in the clinical setting. So if you come to the clinical setting, you are going to have maybe a patient with maybe a T2N1 M naught or T3N2 M naught. And for the T stage, whether it being clinical or pathological, that's when maybe you've done the surgery and sent to the pathology for them to assess. They tend to be the same. So mostly we have what we call TIS, when patient may probably have a Paget disease or DCIS. And we have what we call T1, when the tumor is less or equal to 2 centimeters. And we have subtypes of T1s. And we have T2, when it's more than 2 but less than or equal to 5 centimeters. And we have T3, when it's more than 5 centimeters but it's not attached to the skin or underlying tissue. Then the T4 is when it's cancer of any size that probably has an extension to the chest wall, or probably is ulcerated or is attached to the skin or has podorange. And we have different type of the T4s. But when it comes to the end stage, the end stage for clinical tends to be a little bit different from the end stage for pathological classification. With the end stage of clinical, you are looking at how the lymph node fields when you examine and where you can find them. So in the axilla, is there a solitary lesion that you can easily move? Or probably is it matted or clamped together? Or probably is it fixed? Or can you palpate it in the internal mammary lymph nodes? Or can you, or probably see it on a, how do you call it, CT scan? Or maybe you palpate the supraclav region, you are seeing a lesion over there, or infraclav region, you are seeing a lesion there. That's when you are using the clinical stage. But with the pathological stage are looking at the number of lymph nodes that are involved. So if it's less than, it's 1 to 3, it's N1, PN1. If it's between 2 to 9, it's PN2. And if it's more than 10, it becomes PN3. Then we also have what we call the metastatic stage. The metastatic stage, we can have M0, and we have M0I, and clinical M1 and pathological M1. M0 is, we've done radiological evaluation, you've done your clinical evaluation, you don't see any evidence of metastasis. But sometimes, let's say you've seen a patient with breast cancer, you didn't see any sort of metastasis. A patient is bleeding, or probably is scheduled to have a total abdominal hysterectomy with bilateral salpingo-oophorectomy. And during surgery, they notice that there is a cancer cells on the ovaries. Even though because your clinical evaluation didn't see anything, but on surgery they know that there's a 0.2 millimeter cancer cells on the ovary, it becomes a clinical M0, but it's given the italics I plus, just to let you know that at least there's a microscopic disease of metastasis somewhere. And when it's a clinical M1, that one you can actually see it on your clinical examination or radiological evaluation. And pathological M1 is when probably there's a lesion, just like the patient I spoke about. It has a lesion, we took it out, and pathology said that it was cancerous, so it becomes pathological M1. So the other subgroup of staging is what we call the clinical stage. The clinical stage is mostly used for breast, is mostly used in the research setting. Because when I want to examine, I want to probably analyze patients, you're going to have a lot of subtype. We have the T1N0, T0 M1. So we've, based on studies that have been done in the past, they'll be able to identify how each subtype or which of them tend to behave the same. And based on this, that's why we have the different stage of treatment. So if I want to do any research, I may if, because I know I'm going to have maybe a T0, N2, M0, T3, N1, M0, I'll put them in one stage to become a stage 3A. So that, because their outcomes are all the same and I can easily analyze it, I'm going to analyze them differently. So mostly when it comes to the clinical stages, just to help us in the research settings. So why is it important for an oncology pharmacist to know these, the pathophysiology, the breast biology, and also the staging of these patients. Because ideally, a pharmacist is supposed to be part of an MDT, and you are there to make decisions. Sometimes, if there seems to be, even in well-established environments, if there seems to be, like, let's say, a dose modification, the pharmacist is supposed to be contacted, and the pharmacist will help you tell that, okay, maybe we should reduce the dose by this or modify the dose by this. So for you to prescribe or for you to give medication, you should understand what you are doing. So that's also, it's always essential for us to go through these, and because it will help you know that, okay, these are the type of medication I should select for this particular treatment. And sometimes, as clinicians or as on clinical oncologists, we can always make mistakes, because there be a lot of times pharmacists will bring something to you that, oh, are you sure you wanted to write this? Because you may be seeing a lot of patients and you may easily write a wrong medication. If the pharmacist doesn't understand what he or she is doing, just go ahead and serve the medication as it is, and the patient will come in with toxicities. But if they understand what they are doing, they can come and tell you that, oh, maybe probably patient has a luminal A disease. So why are you considering chemo? Maybe I saw the patient is not too fit. Can we just do hormonal therapy? So, so all these are essential in making decision. And in an environment where we have limited resources, understanding these will help you choose wisely for your patients so that you don't cause any extra cost to the patient. And understanding this, as I mentioned, now there's a lot of ongoing changes that's coming up, even just for the hormonal therapies. If a pharmacist know that these are the benefits of whatever I'm given, they can easily advocate for us to get most of the medication on the insurance. Because if they need to contact any person in terms of decision making, they'll contact the oncologist, fair enough, but they also bring a pharmacist on board. If the pharmacist doesn't understand what he or she is doing, it becomes a little bit disastrous. So to end this presentation, I think our take-home message is, as we've have established, breast cancer is a biologically diverse disease with varying clinical behaviors. And it's always essential for us to understand the biology, pathophysiology, and staging, just to help us in our clinical practice. And that will also guide us in our decision making, predicting prognosis, and influence drug selection. And sometimes, even with this, sometimes there have been instances where patients will even come to pharmacists and ask you, probably, I was diagnosed with breast cancer with another patient. Why am I receiving treatment A and the patient is receiving treatment B? If a patient comes and you as a pharmacist, you don't know why that's the difference. It doesn't let the patient have confidence in you. So it's always good for you to understand your pathophysiology and the biology of cancers. And as I mentioned, at least it helps us to personalize treatment and select wisely for our patients. And in one thing about it is that learning this will help us strengthen our multidisciplinary team meetings so that at least we'll be able to have everybody on board to make a better decision for patients. So thank you very much.
Thank you very much. I think he deserves another round of applause. So thank you very much, Dr. Mervyn. And I think for me, my take-home messages were three. So knowing the types of breast cancers, and then also knowing that we are so important in multidisciplinary committee. And then when a patient comes to you, patient talks among themselves. So when they come, they are wondering, why is this person taking this? And why is this person taking that? So when they come to you, you'd also have to know what is happening in that particular setting. So we'll take our next speaker. Please note down all your questions, and then we'll address all of them after the presenters have presented. So we'll take our second speaker, and he's, like I said, he's the pharmacist head for oncology and radiotherapy units in Kolebu Teaching Hospital. And he is also a lecturer too at a point. He teaches the students as well. So I would invite Dr. Pham Godfred AJ.
Good evening to you all. Waiting for the presentation slides. Okay, so before then, let me acknowledge that Dr. Ajiman hit the nail right on the head when he indicated that it's important for pharmacists to understand how cancer is treated or the pharmacology of cancer. In fact, in his presentation, he made mention of the fact that there is increase in cancer burden. It is therefore important for pharmacists to appreciate and understand how cancer is treated. In addition, he kept on saying that each patient and how the patient is going to be managed. So as pharmacists, how can we be able to identify that a specific patient need this specific treatment? He again went on to mention that we have molecular level of cancer. What happens at the molecular level? He mentioned mutation of the cancer cells, staging of the cancer cells. All these things are very important for us to appreciate the treatment of cancer. So I thank AstraZeneca and Oncology Pharmacy Association for organizing this important CPD. Now, in fact, today my role here is simple: to demystify the mechanism of action of cancer treatment or systemic treatment when it comes to the use of pharmacologic aspect. Okay. The presentation slides. Okay. This. Okay. As usual. That's it. So at the end of this presentation, I want us to understand the pharmacologic principle of chemotherapy, targeted therapy, and immunotherapy. Dr. Ajiman already discussed how cancer of the breast is treated, but it cuts across. The principle is the same. I also want us to understand the mechanism behind each treatment modality, compare and contrast the role of chemotherapy, targeted therapy, immunotherapy, and also recognize that the pharmacy plays important role specifically in the management of or in the handling of chemotherapy, targeted therapy, and immunotherapy to ensure that the patient receives the best of treatment. It is estimated that there will be about 20 million cases of cancer globally this year. And cancer, as I said, is a burden because it's the second leading cause of death in the world. And pharmacological therapies are therefore very important in helping to reduce the burden of cancer. So when it comes to the management of cancer, the treatment modalities are surgery, radiotherapy, chemotherapy, targeted therapy, and immunotherapy. Now, we will concentrate on chemotherapy, targeted therapy, and immunotherapy. If you have time, maybe you can talk of hormonal therapy, but this is the main treatment modalities that we concentrate on. But it's important to note that these treatment modalities are not used alone, as indicated by Dr. Ajiman. We usually combine them for maximum therapeutic benefits, as well as to minimize side effects. So when it comes to the management, there are two broad categories. So we have the local one, surgery radiation. So when, for example, breast cancer is at an early stage, we can use, usually we can use surgery to remove the tumor. When it is at an early stage, we can use radiation to kill the cancer at the initial stage or when the cancer is at the early stage. That's why the staging is important. So when it is at an early stage, for example, stage 1, we can use surgery radiation. But what about if the cancer has spread? What about if the cancer has moved to other organs? Can we use surgery? No, that means that we have to use systemic therapy. So this is where chemotherapy, targeted therapy, and immunotherapy comes in. What is the main goal of cancer therapy? One, we want to either cure, we want to control the disease, or we want to do palliation. So our interest is on pharmacologic therapy or treatment. And it is important, pharmacologic treatment is important for all the stages of cancer, whether stage 1, stage 2, stage 3, stage 4, because it can be used for curative purposes. When it is combined with other form of treatment, it can be used in the adjuvant setting. That is when you have used the main treatment, for example, surgery, and you use chemotherapy to remove or to take care of the micro metastatic cells so that the cancer will not reoccur or to prevent recurrence. It can therapy where it is used to reduce or to shrink the size of the treatment in order to enhance treatment. And it can also be used in palliative setting. That is when the cancer has spread to other part of the body. And it will help in reducing the symptoms of the disease as well as improving the quality of life of the patient. So the symptoms will include pain and maybe cough and fatigue and those things. So what is the role of pharmacologic treatment? One, to either destroy, control, or suppress or kill the growth of, stop the growth of malignant cells. Now, our first systemic therapy that we will talk about is chemotherapy. And chemotherapy is the use of cytotoxic agents to eliminate fast dividing cancer cells. So the key word here is cytotoxic, meaning that it actually kills the cancer cell. And it is it has systemic effect because it travels in the systemic circulation to other parts of the body in order to have its effect on the cancer cells. And because it affects fast dividing cells, normal cells are also affected, hence its side effect. Note that it can be used, chemotherapy can be used for both curative and palliative care. Currently, there are over 100 chemotherapeutic agents, and they were discovered about 75 years ago, but they continue to evolve or continue to um, be used in improving its characteristics to help improving patient care. Now, before we understand how chemotherapeutic agents work, we need to go back to school and understand the cell cycle. So what is cell cycle? Cell cycle is just the simple process where a cell will divide into two identical daughter cells. Why will a cell divide into two identical cells? This process is important because it helps in normal function of the cell, it helps in growth of the cell, it helps in reproduction, it helps in replacing damaged cell. So this process is very important. But note that cancer also undergoes cell cycle. However, with the case of cancer, it is what? Very fast or proliferating or uncontrollable. And chemotherapy takes advantage of this fast dividing process of cancer cells. So the cell cycle is made up of phases, and there are 5 main phases. The first phase is the Gen 1 phase. This is what we call the gap 1. This is where the cell prepares to copy the DNA. We have the S phase. This is where there's DNA synthesis, DNA replication take place. And note that each stage is targeted by a chemotherapeutic agent. So S phase, for example, is targeted by antimetabolites such as methotrexate. Now the G2 phase is where the cell prepares to divide, and topoisomerase will target the gene 2 phase. Then we have the M phase, which is the mitosis phase. This is where the actual division occurs. That's the shortest of the shortest of the cycle, and that is where the cell actually divides into 2 identical daughter cells. Now, there are certain medications that will also affect the M phase. For example, the taxanes and the plant alkaloid. Then the last one is the resting phase, where the cell is resting. It undergoes normal processes, but something has to trigger it before it will divide. For example, the cell like the nerve cell, they don't usually divide. They are mostly resting. Same with the cardiac cell. So we can classify chemotherapeutic agents into 2 main groups. The first group is cell cycle specific, as the name suggests. They will target a specific phase of the cell cycle. So we have methotrexate, which will affect the S phase. We have the taxanes, paclitaxel, docetaxel, will affect the M phase. Then we also have the second group, which is the cell cycle non-specific. For them, they can affect both the any phase of the cycle, including the resting phase. These concepts are very important because it determines the selection of the drug for the treatment. There are certain type of cancers that are fast dividing. For example, non-small cell lung cancer is very fast dividing. So for them, they will be more susceptible to the cell cycle specific. Cancers such as leukemia, they are very fast dividing. So they will be affected, they will be more susceptible to the cell cycle specific. And in the usage, we usually want to increase the frequency. So sometimes we want to give a continuous dose. That's why sometimes we give, for example, day 1 to day 5. Why? The cell is dividing. So we want the cancer cell, we want the chemo to be with the cancer cell to stop that growth. And when it comes to the cell cycle specific, they are usually used for when we use the high dose. When the cell goes into the division, it will target it and kill it. So this is just a summary of what I've been saying. Each medication will target a specific cycle of the cell life cycle. Now, we need to understand the mechanism of action of chemotherapy because this is basically what Dr. Ajima was talking about. It helps us in selecting the best treatment. So the main mechanism of action of chemotherapeutic agents are: 1, disrupt DNA replication. So if DNA replication is stopped, what will happen to the cell division? The cell division will stop, cell will die. It prevents mitosis. If mitosis is prevented, what will happen? The cell cannot divide. Chemotherapy also triggers apoptosis, and this is self-suicide. So when the cell is triggered, it will die, what we call the programmed cell death. So we need to know that chemotherapeutic agents are broad, non-specific. They target all dividing cells. So these are the main groups of the chemotherapeutic agent. We have alkylating agent, platinum compound, antimetabolite, anti-tumor antibiotics, mitotic inhibitors, and finally, topoisomerase inhibitors. So now when it comes to the alkylating agent, what is the mechanism of action? They will attach alkyl group to the DNA. So this one is like, the DNA is like a zip. The zip of Ghana must go back. The DNA has to open before cell division can happen. But when you tie a knot anywhere around it, you can't open it. That's how the alkylating agent work. They will attach an alkyl group. Therefore, replication cannot happen. If replication cannot happen, the cell will die. Example are cyclophosphamide and ifosfamide, and they are used commonly for breast cancer, ovarian cancer, and lung cancer. We have platinum compound. They will cross-link the DNA strand. If you cross-link the DNA strand, the cell cannot divide. The cell will die. Example include cisplatin, carboplatin, oxaliplatin, and they are used for breast cancer, ovarian cancer. The next one is the anti-metabolite. They will mimic the building blocks of RNA and DNA. So the DNA feels that it is building its DNA, but anti-metabolites will go and trick it. So it will trick it in believing that, oh, this is the nucleotide I'm using to build the DNA. When it happens, a false DNA will be formed. And what will happen is the cell will die. We have the folate antagonist, methotrexate, the pyrimidine analog, 5-FU, capecitabine and co. Commonly used for breast cancer, GI cancer. And the other one, the other group is anti-tumor antibiotics. They will bind to the DNA, interfering with replication and causing free radicals, which will damage the DNA. Doxorubicin and bleomycin forms breast cancer, as we know that doxorubicin is for breast cancer. Now, I think last but one is the mitotic inhibitors. You know that it will prevent microtubules formation during the mitotic phase, and when it happens, the cell division cannot occur and the cancer will die. Common one is the paclitaxel and docetaxel, and the finger color you have the increasing vinblastine, and they are using breast cancer, as you know. So the last of the group with the topoisomerase inhibitors. So you know the topoisomerase is an enzyme that is responsible for unwinding the DNA. So if the DNA cannot unwind, there will be a lot of pressure on the DNA, so it will break or it will die. So when you inhibit the topoisomerase enzyme, it will prevent the DNA from, it will let the DNA die and the cell cycle cannot continue. Okay, so we have etoposide and irinotecan. Now, it is important to understand, as Dr. Ajman said, it's important to understand this mechanism because it helps us in deciding the type of treatment that we should give to the patient in order to ensure positive outcome. So it also helps us in personalizing the treatment because it will help us in selecting the products that are effective for a specific cancer. It helps us in predicting toxicity. So if you know you are picking a product from, let's say, the mitotic inhibitors, these are the likely toxicity that you will encounter. And most importantly, it helps us in designing effective combination therapy. I forgot to add that chemotherapy is hardly used alone. In all cancer treatment, usually we combine them. So hardly will you see that a patient is taking one medication alone. So when you know the mechanism of action, it helps us to know how we can design the combination therapy. And you know, cancer too can develop resistance. So combination also helping this, reducing the challenge of resistance in treatment. Now, chemotherapy resistance is one of the challenges in the treatment of cancer. Cancer cells, as Dr. Ajima mentioned, develop mutation along the way. For example, he mentioned of mutation of the BRCA1 and BRCA2. When mutation occurs, it has its effect. It can cause resistance. Cancer cell can actually increase the number of P glycoprotein, and this will cause efflux of drugs. So when the drug goes into the cell, it is pushed out. So you realize that the patient will start treatment, and after some time, the patient is no longer responding to treatment. Why? The cancer has developed resistance. It can increase DNA repair. You know, with the cell life cycle, there are checkpoints. There are something like traffic lights that will give the cell go ahead to divide. So with sometimes these checkpoints are, let's say, inhibited through mutation. Therefore, there is DNA repair. So as chemotherapy is trying to destroy the DNA, to take time and it will repair itself very fast. Sometimes it prevents apoptosis. The cell refuses to die, even though chemotherapy has been administered, it refuses to die. And again, when we mention cancer, it's not just one cell. There are different categories of cell within the cancer. Some of them are mutated, some of them are fast dividing, some of them are slow dividing. So all of this can lead to chemotherapy resistance. How do we strategize to prevent resistance? The use of what? Combination therapy, so that I can target different phases or aspects of the cell cycle. Now, with the chemotherapy administration, we have the IV route, and usually forms about 80% of the administrative route. This is important because it goes directly to the cancer cell in order to have its effect. Same thing with oral route. But there are sometimes we cannot use this route. For example, if the cancer has spread to the CNS, then we have to use the intrathecal route. So the route of administration depends on the type of cancer and how we want the drug to reach the cancer cell. Like I mentioned, or like you know already, chemotherapy is associated with a lot of side effects. The reason being that it is also targeting fast dividing normal cells of the body. What are some of the normal cells that are fast dividing? You have the GIT cells, that is the mucosa lining. They are fast dividing. We have the hair follicle, which is also fast dividing. The skin, the red blood cell and the white blood cell and other cells. So chemotherapy is associated with side effects such as nausea and vomiting as a result of breakdown of the mucosa lining. Alopecia because it is destroying the hair follicle, myelosuppression, mucositis. So the whole idea in cancer treatment is you want to use the highest dose possible, but at the same time you want to minimize the side effect caused to the patient. So that is the basic principle of cancer treatment. So as pharmacists, even though Roja will talk about the role of the pharmacist when it comes to the chemotherapy specifically. These are some of our roles as pharmacists: calculating the dose, monitoring for side effects, and educating the patient. As I mentioned earlier, we are moving into a new area where we use targeted therapy instead of chemotherapy. The reason is that chemotherapy doesn't differentiate between normal cell and cancer cells. So we are moving into the targeted therapy area. So what are targeted therapy? They are new medications or novel medications that act on specific molecular targets in cancer cells. So this one, there's a specific characteristics of the cancer cell that we want to target, and they are designed using tumor genetic profile. The advantage, as I said, is they will spare the normal cells, and they have minimal side effect, but they are often biomarker driven. So before a patient can take a targeted therapy, they mean that the patient has done a biomarker test. These are the difference between chemo and targeted therapy. With chemotherapy, you know it's not specific, it's cytotoxic. It will destroy cancer cells. But with targeted therapy, they are cytostatic. They spare normal cells. The side effects for targeted therapy is minimal as compared to chemotherapy. These are characteristics of cancer cells, what we call the hallmarks of cancer. So cancer cells specifically have these characteristics. So our aim in targeted therapy is to identify a specific characteristics of a cancer cell, and we target it. So let's just pick an example such as EGFR. So EGFR has been are proteins that are found on surfaces of certain cancer, such as lung cancer. And they've been identified to sustain proliferative signaling. It means that they keep on informing the cell to grow, proliferate, and to survive. So when you inhibit that process, it will stop the cancer from growing. There are 10 of these special characteristics of cancer cells. So each and every day, there are research that is ongoing to be able to identify which of these characteristics that we can target in order to kill the cancer cell. So these are some of the molecular targets, and these molecules or proteins are found on the surfaces of the cancer cell. For example, we have the EGFR, and EGFR is a signal which will tell the cancer cell to keep on proliferating. So if we have a medication that will stop it, it will stop the cancer cell. An example is the erlotinib and osimertinib. So these are medication that will specifically target EGFR protein on the cancer cell. We have our HER2, which we all know. So they are also proteins found on the surfaces of most of the time breast cancer, GIT cancer, and they cause proliferation of the cancer cell. This protein is found on the surface of white blood cells, and when you block it, it affects that. Another example is VEGF, which is also found on the surfaces of cancers, just like the GIT. So drug like Avastin, bevacizumab will stop angiogenesis. So what I want you to notice is that, number one, these are proteins found on the surfaces of cancer cell, and targeted therapy will target each of these protein. And when not each of these, but based on the condition, and when a protein is targeted, it will stop the growth of the cancer cell. But before we can use any of this, it means that we need to do a biomarker test, as I indicated earlier on. There are two types of targeted therapies. The first one is monoclonal antibodies. So monoclonal antibodies will bind to the surface, not inside, but outside, the surface of the cancer cell. So it will bind to the antigen on the surface of the cancer cell, and it will trigger immune response or inhibit the signaling, or what is telling the cancer to keep on dividing. We know trastuzumab and bevacizumab already. Then another type of targeted therapy is the small molecules. An example is the tyrosine kinase inhibitor. Tyrosine kinase is a protein which is found inside the cell, and it induces signaling so that the cell keeps on dividing. But medications such as imatinib and osimertinib enter into the cell. So it's small molecule, it actually enters into the cell and stop this signal process. Other targeted therapy are the PAP inhibitors, as mentioned by Dr. Ajiman. PAP inhibitors will, in fact, PAP enzymes helps in targeted therapy is associated with some side effects, and these side effects depend on the molecule that we are targeting. So we have rashes, we have diarrhea, hypertension, and liver function. Diarrhea is very important because they affect the GIT. Rashes, hypertension, and liver dysfunction. So note these common side effects associated with targeted therapy. And targeted therapy can also develop resistance, and it is due to secondary mutation. For example, one mutation can change to another mutation over a period of time. And when it happens, we have to rebiopsy. We have to do the biopsy again to identify the new mutation so that we can target that particular mutation. So as pharmacists, we need to ensure that that biomarker testing has been done before we give targeted therapy. So in the clinical setting, you cannot give trastuzumab without confirming that the patient is HER2 positive. Same thing with imatinib. We have to make sure that the patient is EGFR positive. We need to monitor the adverse effects of this. Okay. Now, the last pharmacologic treatment we are going to talk about is immunotherapy. In fact, we are moving to precision medicine where no single patient will be given the same medication like any other patient. As Sharon said, the patient talk among themselves, but the treatment that one patient is taking will not be the same as the treatment another patient is taking. Okay, so what is immunotherapy? Immunotherapy is when we are using the body's own immune system to treat cancer. It will stimulate the body's immune system to fight cancer, and it will restore immune surveillance. It will overcome immune invasion. You know that the immune system has certain breaks so that it doesn't overreact. It's important to note this because this forms the fundamental of our understanding of immunotherapy. Cancer cells take advantage of this to hide or to make themselves not being able to be identified by the immune system to be destroyed. Under normal circumstances, if the immune system is strong enough, it's able to kill the cancer cell, but the system has its own break so that the immune system doesn't overreact. Now, when we use a medication, and the first and most important of all the immunotherapy is the immune checkpoint inhibitors. So immune checkpoint inhibitors will remove the inhibitory signal on the T cell. You know, the immune system, we have the T cell, the B cell, the lymphocyte, basophils, and those things. So with the T cell, checkpoint inhibitors will remove that break on the T cell. So drugs such as pembrolizumab and nivolumab will remove that. So when that system is removed, what will happen? It will be able to help in identifying the cancer cell and target it. The first example is the PD-1 inhibitors. The second one is the CTLA-4 inhibitors. So they will remove the brakes on the immunotherapy bodies or molecules in order to target the cancer cell. This is a demonstration of what I'm saying. Now, another example is the CAR T cell therapy. And with CAR T cell therapy, the patient T cells are engineered to recognize specific tumor antigens, and they are highly effective in blood cancer. Other ones also include oncolytic viruses, where viruses are engineered in order, they are engineered and they are injected into the patient in order to infect and kill the cancer cell. We also have cancer vaccines for prevention of cancer, such as cervical cancer. And we have cytokines. With cytokines, immunotherapy agents such as interferon or interleukin-2 are injected into the patient, and it helps in identify and kill cancer cell. Now, before you are giving immunotherapies, you need to undergo biomarker tests as well, as in the case of the targeted therapy. But this is very important because these are serious side effects associated with immunotherapy. We call them immune-related adverse effects. And as pharmacists, it's our responsibility to able to identify these side effects early for effective treatment. So colitis, usually it will lead to diarrhea. We need to, so if a patient is on this medication, you identify that you need to report early. We have pneumonitis, hepatitis, etc. Now, the main strategy for management is early identification and intervention, and the use of corticosteroid and multidisciplinary team collaboration is also important. Now, so as pharmacists, as I indicated, we need to educate patients about side effects of immunotherapy, monitor and report immune toxicity, promote treatment adherence. But mind you, these medications are very expensive. So I'm trying to conclude, and my conclusion is that, see, we don't use one treatment for the management. That's why we needed to go through these processes to help us understand how the selection of this treatment is done within the clinical setting. So sometimes you see that we combine chemo with immunotherapy, as demonstrated by Dr. Ajima. Sometimes you combine targeted therapy and immunotherapy, and this will enhance treatment efficacy and importantly, prevent resistance. Is very important, and it will improve treatment outcome as well. And we are going into the world of precision oncology, where no one patient or two patients will not receive the same medication. The medication you take will be different based on advances that we are undertaking. So there will be tailored treatment based on genetic profiling. There will be a stage now where every patient, you undergo genetic profiling, and we see that, oh, you need PAP inhibitors, or you need, which one? Trastuzumab, based on your profiling. You have BRCA2 mutation. And these things are done by the pathologist. So just a simple request that I want biomarker test for this. They use the tissue from the patient, and that is the future of oncology. So that is what I wanted you to be aware of. And it will help in supporting personalized treatment decision. And I said, this is the future of oncology. So as pharmacists, we play a very important role when it comes to cancer treatment and management, because we optimize treatment outcome. We ensure that we deliver patient-centered care. So summary, number one, chemotherapy. We are not removing chemotherapy from our treatment because most of the cases, the cancer is even detected at the late stage. But like I said, chemo will what? Destroy or kill the cancer cell. So chemotherapy is still very important. And though it is broad, it has a side effect. Targeted therapy is the future because it helps in precision approach based on your tumor type. So no patient will receive the same medication. Immunotherapy, even though currently I think they are about about maybe 10 immunotherapy that have been approved. It is still a new area that we are exploring, and it's also very promising. And pharmacists are important in ensuring safe and effective use of these medications. So the conclusion is that let's work together to transform cancer care, and one patient at a time. Thank you.
Okay, thank you very much, Farm Godfred. So I think we've also, if you look at the flow, we did the basics of oncology, and then we've also done the pharmacy bit of oncology as well. We know there's several types of chemotherapy, targeted therapy, immunotherapy. So cancer is evolving. And I believe that in the past, maybe 5, 10 years ago, it wasn't something that was of concern. But now it is a big issue. So our next presenter would please note down all your question. And the last presenter is going to present on the role of pharmacists in MDTs. And I think this particular topic is very interesting for me because pharmacists need to be in multidisciplinary committees to also talk about the drugs. So we would invite Farm Roger He's also an oncology pharmacist. And
right? But we'll just take some time and take a look at some of the things. I saw Auntie Amma around, but I can't see her anymore. Okay, I want to acknowledge her. Yes, thank you very much. So we'll move straight to, am I going the right way? All right. Well, I have nothing to disclose. All right. Thank you. So this is going to be my outline. Multidisciplinary care defined, composition of the MDC, the oncology pharmacist, the roles that he plays or she plays, essential skills required, then the roles of an oncology pharmacist, and then we'll conclude. Now, a multidisciplinary care team is defined as integrated team approach to healthcare in which the medical and allied healthcare professionals consider all the relevant options and develop individualized treatment plan for each patient collaboratively. And the catching word or the catchword there is collaboratively. All right. The composition of the MDC, as I mentioned earlier, it includes This list is not exhaustive. Where is the pointer? Okay. The list is not exhaustive. It includes the pediatric oncology pharmacists or the pediatrician who coordinate most often the deliberations at the MDC team meetings. It includes also the radio oncologists, the surgeons, the the general surgeon or the pediatric surgeon. Now, the surgeons that operate oncology cases are not general practitioners. They have to be trained in how to operate cancers, all right? So these undergo specialized trainings in order to become oncology surgeons, if I should put it like that. We also have neurosurgeons, maxillofacial plastic surgeons, you have pathologists, you have hematologists, microbiologists, radiologists, nurses, pharmacists, dietitians, psychologists, occupational therapists, play therapists, and the list does not end there. You will see play therapists. During my presentation, I may be leaning towards the children. All of them were leaning towards the adults. So I'll be leaning a bit towards the children. Is that okay? Now, because, children, for example, in trying to maybe carry out a procedure on them, they can be very, very troublesome. So we have a play therapist. In an adult team, they may not need a play therapist. But for the pediatric team, we need a play therapist that can help, move the child's attention away from whatever procedure or the things happening around so that the procedure can be carried out. Is that okay? So we need a play therapist over there. We need a dietitian. In fact, we went to one facility where when we go for ward rounds, you see that the dietitian is right there whilst the ward round is taking place, so that decisions that are taken, which will be affected or influenced by diet, will be implemented by the dietitian. So the dietitian forms a very important part of the MDC team. There's just a picture showing the same thing. Now, why MDC team? We know that cancer care is complex, all right, and needs different experts in managing it. Therefore, these experts work together to plan, implement, and monitor the treatment and care. MDC team helps communicate among the experts. For example, if maybe a patient you are now working up the patient, you are investigating, trying to conclude on the diagnosis, and then stage the cancer, all right? Maybe you need to take a biopsy, do a biopsy. The surgeons are part of the team. So in our multidisciplinary team, our child health department, for example, every Friday, we have our multidisciplinary team meeting. So at that meeting, communication is, sent out to the surgeons that, okay, patient A is coming, or we need to do biopsy for patient A, therefore is coming. Then they quickly arrange the process of getting the patient to the surgical department, going through all kinds of protocols is limited because there is direct communication of those to those who will be doing the biopsy. All right. So it helps a lot to communicate among the experts. It facilitates decision making and coordination necessary for provision of care. If it is radiotherapy that needs to be done, the radiotherapist is right among us. As deliberations are going out, they'll say, okay, bring the child on this day at this time. And when that day comes, the patient and the caregiver, they are sent to the radiotherapy, and then the procedure is carried out. It reduces the time needed to gather information about the cancer, and to develop the plan of treatment, because all the aspects are at the table. So inputs are made from the different aspects so that a decision is taken for implementation. Now, research has shown that the multidisciplinary team approach leads to revision of cancer diagnosis and treatment plans in new cases. This was by Pollock, TM, and Heruban et al. And also, it has shown that there was a prospective study of the clinical impact of multidisciplinary clinic on the management of pancreatic cancer in 2010. These show that multidisciplinary teamwork is very helpful. So compared to multidisciplinary teamwork, when they were, not involving the other aspects in diagnosing these conditions, they realized that when they involve other disciplines, they had to review or change the diagnosis because other input from various experts came in, which changed the diagnosis. Am I communicating? All right. There was also a study by Vinod et al. On the multidisciplinary team meetings guideline-based care in terms of evidence-based guidelines. You see that when you involve a multidisciplinary approach, or when you use multidisciplinary approach, they are able to adhere to the guidelines compared to when only oncologists are treating the patient. Because in the multidisciplinary approach, all the experts at the table are making the relevant inputs, then the way forward is synthesized and then implemented. And then there is also monitoring of progress as the implementation is done. Research also has shown that there is increased patient satisfaction when we use multidisciplinary teams, because relevant inputs were made, which were implemented, monitoring took place, and outcomes were better, and therefore patients get satisfied. So there is a lot of evidence out there that show that the multidisciplinary team approach is the best way of managing cancers. Now, multidisciplinary team meetings also is a very good opportunity for learning. So if you are a pharmacist and you have the opportunity to participate in these team meetings, it gives us opportunity to learn a lot as various cases are discussed, from various angles, inputs are brought on board, we are able to learn a lot. What does the MDC team do? So they help diagnose and stage the cancer. It develops personalized treatment plan, considers all available treatment options, monitor and review the treatment during and after completion, and also evaluate the impact of treatment on the life of the patient. How does the MDC team work? They meet regularly to discuss current developments and monitor the progress of patients. Other experts with great experience not available in country may be invited occasionally. We've had occasions where we have some brain tumors that need to be worked on for some of the children. at those meetings, there is one prophet, Beaufray, I think in Canada, who could be contacted by our lead oncologist, brought on board by Zoom, makes relevant inputs into the management, because there are cases that we have not handled before, but they have handled it, and though they can be, brought on board to make relevant inputs that help in the treatment of such patients. So it's very helpful. Now, we now go to the oncology pharmacist. He's a specialized healthcare professional who focuses on the medication management and therapeutic care of patients with cancer. And we focus on the safe and effective use of the medications to treat the cancer. We do not work alone, but we team up with oncologists, nurses, and other healthcare professionals to ensure that cancer patients receive the most appropriate and effective drug therapies. And that is very, very important. In the presentation of Dr. Godfred, he said cancer wants to live forever. They are striving for eternal life. So they are swerving all kinds of approaches we are using to eliminate them. So we must be strategic enough, use all the expertise we need, to overcome them. All right? So teamwork is very important. There are essential skills that are required to practice in the space of oncology. There are certificate training of Bachelor of Pharmacy or Doctor of Pharmacy graduates authorized by, institutions such as the Ghana College of Pharmacists. Okay, and that is the beginning of the journey to specialize in this field. Because before you can operate in the oncology space, you need some specific training, skills acquisition, and knowledge acquisition. Sorry. Then there is also there is the postgraduate residency training in oncology pharmacy from the college, the Ghana College of Pharmacists is making that available. And also there is fellowship program in oncology pharmacy by the Ghana College of Pharmacists. Now I put this one here to show us that, acquisition of relevant and recognized training by the appropriate authority by either a pharmacist, nurse, or technician may equip such a cadre to play a role in a specialized area of oncology pharmacy. Because you go to certain jurisdictions, it is not the pharmacist alone that is reconstituting medication or is involved, in what we do here. All right? There are places where it is the nurses that are reconstituting or preparing chemotherapy. There are places where both nurses and pharmacists are involved. And also there are technicians. So what is important is that the person must be trained. However, if you are a pharmacist, you are in better position because of the kind of knowledge that we have and the skills that we have per our training to impact the practice better. What are some of the roles? We have clinical roles. We work with the management and other stakeholders to ensure stocking of safe and efficacious anti-cancer and supportive medicines in the hospital. So this is just one of our primary roles that we play to ensure that safe and efficacious medications are available. And that can go beyond the hospital, because we can, let's say in the FDA and other, regulatory authorities, we need to influence those decisions as well in a positive way, make inputs that will be helpful. We help with medication management and safety. We review and verify chemotherapy orders. So some of these things, I will just go over them because, let's say, for example, a patient is diagnosed, staged, and assigned appropriate protocol. All right. Now, that patient is taken through counseling, or the caregivers, for us, because we are dealing with children, so they must be taken through counseling for them to understand the disease condition, the treatment options available, duration of treatment, the side effect to expect, and the cost of the treatment, and everything they need to know. Any question they ask, and then we answer them. Now, after after that counseling session, they have to make they must agree, consent to receive the treatment. Once they have signed the consent form, the next thing is to initiate the treatment. Now, the oncologist reviews the patient, and the patient is fit to receive, for example, chemotherapy. If it is chemotherapy, this patient is supposed to receive. Now, the prescription order is sent to the pharmacist for the pharmacist to prepare. I will use chemotherapy in this case as the medication that the patient is supposed to receive. The order comes to the pharmacy, and the oncology pharmacist is expected to what? Review the order to make sure that this is the right patient, the diagnosis is correct, the protocol is correct, the vitals are there, your BSA or whatsoever you are using to determine the dose, they are correct. Then you go to the medications. Are the medication prescribed for the right routes? The medications, are they correct? Then the dosage, is it correct? Is there the need to modify the dose? You have to answer that question. Now, if the dose is to be modified, what is the expected dose to be taken by this patient? What is the route by which this medication is supposed to be administered? Is it supposed to be a slow push, or is going to be an infusion? Now, what is the frequency of the medication to be taken? Is it the one-time medication to be administered, or is supposed to be taken for maybe 2 consecutive days or a certain number of days? Now, as the oncology pharmacist, it is my responsibility to look at the protocol and find out whether that which the prescriber or the oncologist has written in the other form is accurate or not. If it is not, if something is wrong, I bring it to the attention of the oncologist, and then we can get it corrected. If it is okay, then there is a portion for which that I have to sign. I endorse it, say that, okay, it has passed, and therefore we can then go ahead and then input relevant information into our records, generate the label, assemble the raw materials, and go in using standard operating procedures and other systems, go ahead and prepare the chemotherapy for this patient. Let me give you a typical example. Just about a month ago, there was this patient who had the germ cell tumor, which is a tumor of the reproductive system, and is supposed to take etoposide for 3 days, first day 1, day 2, day 3. Is supposed to do carboplatin day 2, bleomycin day 3. Now, when in calculating or evaluating the doses, realized that the bleomycin dose was quite small. So I was curious. So I went to the protocol and looked. I saw the dosage. It was, I think, 1,500 milligrams per meter squared. Came back. Per that, the dose that was written was correct. But something was nudging that something is wrong. So I further read through the scriptures, and I called one of the consultants and said, this protocol, there seems to be something wrong with this protocol because the dose is too small. So we looked through and talked, and then she told me, yeah, it is true. The dosage is supposed to be 15,000 IU per meter squared, not 1,005. Now, what has happened was that an old protocol was attached to the patient's other form. Okay? Now, if by experience one had not been associated with, the protocols and knowing the content, would have passed it, would have prepared, it would have been given. All right? But by reason of the skills and the knowledge that we have gathered, we're able to make that intervention. That wrong protocol was taken away, and then the new one was put in there, and then we're able to save the situation. So the role of the oncology pharmacist is very key. We monitor patient responses, check for side effect, drug interactions, adjusting treatments in collaboration with the healthcare team. We don't do it alone. We always work as a team. And as a team, you must play as a team player. You don't go accusing your other team members, all right? You must interact with them in a kind way, and then the team will be able to profit our patients. We ensure safety and compliance. We make sure medications are stored and handled safely as per guidelines in handling toxic medications. Regarding chemo preparation, we prepare and dispense chemotherapy, ensuring that they are prepared in sterile environment, ensuring safety for both patients and healthcare staff. We also provide counseling services. We educate patients and caregivers, explaining to them how the medications work, the side effect to expect, and how to manage them. These help them alleviate all their fears, and they are able to, comply and adhere to treatment. We play a role in clinical research, both operational research and others. Training of MDC team members on safe handling of toxic drugs is another role that we play. Now, regarding medication safety management, we do this by participating in ward rounds, multidisciplinary ward rounds, and also pharmacy-led ward rounds. And through that, we are able to optimize medication regimen through monitoring for side effects and making appropriate interventions. We ensure adherence to treatment. Sometimes you go on those ward rounds, you go and then you look at patient treatment sheets, and then some medications have been prepared, but they are not, administered. You have to engage the nursing staff, for example, how come this was not administered? Perhaps forgetfulness or too much work or other reasons. You make appropriate interventions so that those medications are administered. There was a situation, there was a patient who was just taking some oral cytotoxics and was supposed to be on antiemetic, on dancetrone, and she was instructed to take it 12 hourly. Normally, 8 hourly on dancetrone is what is required. But then she was instructed to take it 12 hourly. And she came back. So through interrogations and the communication, she was complaining that still the child was vomiting, okay, in spite of the fact that she was taking the antiemetic. Upon further probing, that was when I got to realize that she was taking it 12 hourly. When we changed it to 8 hourly dosage, the nausea and vomiting ceased and the child was better. We also provide discharge counseling to patients and caregivers. So when the patient has come on treatment, needed to be admitted for the treatment, patient has finished receiving therapy for that course and then is being discharged. There are, say, medication that need to be taken at home. We provide counseling as to how those medications should be taken and when they should be taken, which precautions that must be observed. We inform them on that. We also counsel them on how to handle, say, body fluids, all right, because some of those medications, it is assumed, for example, that oral cytotoxics, they are less harmful than the parenteral cytotoxics. That is a myth. It is not true. Therefore, they must be, counseled as to how to handle, for example, body fluids, okay? How to double flush when they use the WC, or that there are other children in the house, all right? In order not to expose them, they need to double flush while the lid is closed so that those in the house, don't get unduly exposed. Even if the child is maybe wetted, let's say the child is using a diaper, how to handle even the diaper after it's been wetted, all right? All these things, we are responsible to counsel the caregivers so that they can do these things properly and not be affected by exposure to these agents. All right. So there are other medication safety measures. For example, we monitor and manage potential drug interactions like, let's say, high-dose methotrexate medicines, which is supposed to be given. Now, usually, when a medication is supposed to be given, you want to find out, are there other medications that the patient is already taking? Is there the possibility of drug-drug interactions? If there are such possibilities, then you have to make the appropriate intervention so that the patient does not experience that. So, for example, for high-dose methotrexate, any patient who is about to take that, should the patient be on, say, Septrin, penicillin, derivatives, aminoglycosides, ciprofloxacin, etc., these medications should be stopped at least 72 hours after the start of the high-dose methotrexate. Okay, before they come, they must stop, and then 72 hours after, they must not be taken because they will inhibit the elimination of methotrexate from the system, resulting in toxicity. A drug, for example, like doxorubicin. We know doxorubicin is cardiotoxic. Therefore, if the patient, a patient is supposed to be on doxorubicin, such a patient, we have to first, before we even initiate, we have to check whether there is any issue with the heart, right? So an echo is done before, and then periodically, as per the protocol requirements, to find out whether the heart is being negatively affected, all right? If this patient already has problem with the heart, then we may have to what? Substitute the doxorubicin with another medication that does not have such a side effect on the heart. A drug, for example, also like cisplatin, all right, which we know is toxic to the kidney and also, impairs hearing. It is our responsibility to bring to attention that these are the possible side effects. So for example, for SAT patient, before they start with cisplatin, they go for audiological examination, all right? And also there are regular examination to see if the administration or the therapy is having any adverse effects on their hearing. If it is, then if those modification is needed, it has to be implemented. So we talked about another role, which is preparation of chemotherapies with the check-in procedures, as I had already enumerated. I will not go over it again. Then we do our general documentation, generating the correct labels, assembling our raw materials, ensuring that the chemo preparations are done using the appropriate standard operating procedures. And also we make sure we validate all our equipment and make sure that the products that come out are correct, right concentrations of medications, all right? And also ensure that these medications are stored and administered properly. These are some of the things we look for. I have mentioned them already in my submission, so I'll not belabor the point. In checking our chemotherapy, ensuring safety, these are the informations. I have mentioned them already, so I will not go over them again. In those calculations, we check all those, making sure that the right doses are calculated. And it is so important because I'll give you another example. This also happened about 2 months ago. This one, the oncologist has filled the order, the dosage. Let's say a patient is taking maybe 25 milligrams per meter square of doxorubicin. And then in the protocol, that patient is also supposed to take, let's say, methotrexate as maybe 3,000 milligrams per meter squared. In filling the order, the oncologist somehow, for some reason, used the dosage of the methotrexate for the doxorubicin. All right. So when you see something like that, I saw it. So no, there must be some problem. When you go, you cross-check against the protocol, you'll be able to figure it out and correct. So dosage checks, even if it is the professor who has filled the order form, as the oncology pharmacist, you need to go over and cross-check the details. All right. So we ensure safe preparation of chemotherapeutics. I think I have done justice to all of this. Making sure that the finished product that is moving out of the pharmacy is for the right patient, right dose, in the right diluent, the right concentration, properly labeled. There is no issue in terms of the composition. And then it is stored appropriately under the right conditions. Another thing that we do as oncology pharmacists is to make sure that the lab parameters of each patient are properly documented, because these will affect the doses of the medications that are administered, so that if there is a deviation, if there is a problem, we can make appropriate interventions as early as possible. Keeping the patient profile, monitoring them so that interventions can be made. We also play a role of education and training. So students who come to the hospital, either they are graduates or They are in school training. They come, the house officers, they come, we train them through oncology practice. We educate them on oncology practice. Also technicians in safe handling and reconstitution of cytotoxic. We train all cadres of healthcare team, the doctors, nurses, orderlies, and everyone who handles cytotoxics. We train them in safe handling of such agent because of their toxic nature. We also help ensure appropriate standard protocols are developed. Standard operating protocols are developed in our facilities, all right? And we also play a significant role in ensuring that there is adherence to such SOPs and also review them regularly when needed. Another role of the oncology pharmacist is to facilitate or participate in regular review of treatment protocols and updates to maintain the best practice. How about non-pharmacy staff, training and certification? It is the job of the oncology pharmacist to help train all these as well. I believe the time is coming when we must certify, for example, technicians, right? Either OPAC or Ghana College of Pharmacists or Pharmacy Council must certify these cadres of professional before they step into the pharmacy space. Currently, Ghana College of Pharmacists is doing the 2-month course. We have some gentlemen around here. They are the current batch, all right, who are certified to operate within the oncology space because special skills and knowledge are required in handling these agents. Now, importantly, unqualified technicians, pharmacist assistants, pharmacy undergraduates should not be permitted to prepare or check these agents. Counseling of patients and caregivers, I have already mentioned that. Research, clinical and operational research, we participate in designing of clinical research, monitoring of new treatments, provide understanding and insight into efficacy of drugs and their safety, and conduct operational research that improve processes and safety of patients, caregivers, healthcare personnel, and the environment. We also play the role in the policy and regulation. It is the oncology pharmacist's responsibility to collaborate with the MDC team and all other stakeholders to develop policies that regulate and ensure best practice within the oncology space. And this includes making relevant input that ensure availability of safe and efficacious anti-cancer agents and supportive care medicines that are affordable and accessible. So in conclusion, the oncology pharmacist is a vital member of the MDC team, and is actively involved in the improvement of patient outcomes and enhancement of safety and efficacy of treatment. It is a teamwork. One cadre cannot do it. We do it together to better the outcome of our patients, to make treatments more effective, and also to remove delay in the processes of diagnosis, planning, initiation, treatment, and monitoring. Thank you very much for your attention. I hope I have not bored you. All right.
Thank you very much, Fam Roja. And I think so we are done with the presentations. What we'll be doing is to be taking some questions. Yes. So I think beginning of the meeting, I should have introduced our chairman for the event, but he's aware he's the chairman. So yeah. So it's actually Famobri Eboa, and I'm very sure those of you who started oncology and those of you who know Famobri, you know that he has been the oncology pharmacist, making sure that people are coming into the space and all of that. He started a lot of works in oncology. So please let's appreciate. Right. So I would open the floor for questions. The first speaker, the second speaker, and then the third speaker. Any questions from the house? You must have questions. So I saw that some of you were writing and taking notes. So we'll use some 25 minutes for question and answers. Dinner is waiting for us. So as you can see, some of us, we are all hungry. So question time. Please, onliners, do we have questions online? Then you understood the course. So, ish. Any questions? Okay, sure.
Thank you. My
Please,
name
you
is
introduce yourself and then the facility you are from.
okay. My name is Clement from Dusty Pharmacy. My question is to the second presenter. Doc, I wanted to find out with precision medicine, it costs a lot of money. Currently, the first speaker said, even with the diagnosis, we are having difficulty with targeting these proteins and the likes. But you made us aware that that's the future of it. How soon do you think we can have it in Ghana? And what's the cost involved? If we are even having problem with diagnosis, then treatment will be extra problem. And what are we to do to have these insurance companies and the national health insurance to come on board, first of all, with the diagnosis and also with the treatment? Thank you.
I think you started with diagnosis, so I'll give it to Dr. Ajman to start with the diagnosis. I'll do that.
Okay, so in terms of diagnosis, okay, currently I know there's something in the pipeline, but a little bit political, so we can't really talk much about it. So we are trying to see whether you'd be able to engage government to at least cover a lot of the costs so that it will make it a little bit less burdensome on the patient. So until it becomes fruitful, we can't talk much about it here. But otherwise, everything has to be out of pocket. And sometimes what we tend to do is, for instance, let's say like breast, some of the labs, the actual cost for the histopathology and the biopsy is supposed to be high. But because we are getting a lot of patients, we can talk to them so that they'll be able to bring the prices down. And some of the pharma that also has a little bit of laboratory association. Sometimes they see how best they'll be able to provide them with equipment and reagents just to be able to cut the price down.
Okay, so like you rightly indicated, targeted therapy is still in the evolving stage. In fact, some of them are available in Ghana. Currently, we have about 200 of these targeted therapies that have been approved by the US FDA. I can say considerable number is available, and big pharma companies like AstraZeneca and others are also helping in improving the availability of these medications. In fact, they are expensive, as you have indicated. But from my experience, I realized that when there is improvement in knowledge and there is increase in the usage of these medicines and they become available, it tends to reduce the cost of this medication. So we are all hoping that, for example, I think one of the medication, the osimertinib by AstraZeneca. They are trying to make it available in Ghana and reduce the price as well, right? And reduce the price. So let's hope that that will be the future, and it will help in improving the cancer bed. Okay, Dr. Ajima, I want to add something.
And just to add on to the precision medicine aspect, sometimes you look at it from, like, let's say maybe chemo is cheaper, but like say target therapy is expensive. But also one thing we forget is the indirect cost of treatment if patient gets a toxicity. Because if patient get toxicity, sometimes they are paying more to recover from that toxicity, and that's one thing you don't want patients to do. So sometimes at the end of the day, looking at the whole picture, if you're able to get a good price for some of the targeted therapy, it tends to give a better outcome and reduce some of the toxicity. That doesn't mean targeted therapy doesn't have toxicity; they do, but sometimes they are relatively milder. But compared to some of the cytotoxic agents, it tends to be much better.
Thank you very much. Famroja, please, this goes to you. With the MDT participation of pharmacists, is it out of place for pharmacists to extend their role in involving themselves with administration of the drugs they prepare? You know, in administration, sometimes accidents do happen, like extravasation and other things. Is it out of place to teach the pharmacists to also know how to, or to participate with the administration of the components they prepare? Or it is just a case of you prepare the food, don't participate in the eating?
Thank you, Famanas. In fact, this food, you don't want to eat it. Yes. So you prepare the food, but one thing is that with our knowledge, we are able to make inputs regarding the administration as well. At the daycare, for example, if, for example, an extravasation occurs, the nurses run to me, say, what do we do? Okay, are we going to do hot compress or we are going to do cold compress? For those that have not been trained. So we have been training the nurses and other cadres of the team as to how to manage something like extravasation. So it is important for us to know how the medications are administered, not only how they are prepared, so that if there is any reason that we make certain interventions, we can make them. For example, also, there was a time that one of our oncologists, there was, I think, one medication which we had not used before. One patient is about to be, given. So she doesn't know how to, make the request. So she contacted me, and then I researched it and then made that information available, how it should be administered, for how long it should be administered and everything. And that was what we implemented, and it was effective. So in fact, we must equip ourselves to be relevant in that space as well. Thank you.
Okay, there's a question online. Where is it?
Okay.
I can't choose.
Please, can I ask my question?
Oh, okay, sure. Please ask your question.
My name is Rashid Salim. I'm a pharmacist from PharmaDeals. I really enjoyed this information session, I must say. I enjoyed all presentations. My question is simple. I would want to ask Gode, how receptive are caregivers with regards to these newer therapies? Considering the fact that these conventional therapies, most of them are on insurance, and then these newer therapies are relatively more expensive. So how receptive are the caregivers to newer therapies in management? Thank you so much. And secondly, what efforts would caregivers do to sort of integrate these newer therapies into management? Yeah, so these are the two questions. Thank you so much.
Is it me or okay? I'm still. Yes. Yeah, it was the question wasn't so clear. Or you want? So let's
Oh, can I come again?
please do.
Okay, so I was asking, how receptive are caregivers to these newer therapies, considering the fact that they are more expensive, and also the conventional therapies, most of them are being covered by insurance. So how receptive are caregivers to these newer therapies? And also, what efforts or approaches would they do to sort of um, make the integration of these newer therapies easier for management? Thank you so much.
Okay. Thank you so much for the question. So first and foremost, I must say that some of these targeted medications are locally available. So we can talk of trastuzumab, we can talk of Avastin, which is bevacizumab, fulvestrant, a number of them, erlotinib, a number of them are available. For the reception, yes, it is available, and it is the knowledge is also available for its use because of the effectiveness. But the issue is, as Dr. Ajima indicated, cost of that, even the biopsy. The cost of biopsy is high. The cost of the medication is high. NHIS is unable to put these medications on the NHIS medicine list because of the high cost. But we have seen a gradual trend in terms of request, use, and availability because of its effectiveness. So it's kind of the rich are able to afford it. But as I indicated earlier on, pharmaceutical companies are, as much as possible, trying to let it be available. AstraZeneca is one, Roche is one, a number of pharmaceutical companies. We also have NGOs that also donate some medication to us, which also makes it available. So we are all hoping that there will be a point in time where these medications are readily available and patients will get them as and when, because he was commenting.
I think the other thing is now the increase in knowledge and internet is making patients and relatives more knowledgeable about medications. Okay. So sometimes even patient relatives actually comes to you to discuss some of these things. You just let them have to understand the costs and the benefits. If it's affordable, they go in. Some patients are sponsored by companies. If it's affordable, companies will pay for them. So we shouldn't always think that, okay, because Ghana, we shouldn't look at Ghanaians to be the same. We are different. We are coming from different background. But the issue that sometimes, okay, there's the best, but even if there's not, you can't afford the best, there's other options. So that's what we always not make decision from. So we always let them understand the standard of care. Then based on that, they'll choose out of it.
Any in-house question?
Thank you very much. I am Isaac Bekwen, Holy Family Hospital, Bricum. My question goes to Dr. Ajimai. In your presentation, you made comparison of the recurrence of the types of breast cancer, the HER2 and then lumina and then the triple negative. And from that, you made us aware that recurrence of HER2 positive breast cancer is very common during the first years for HER2 positive breast cancer compared to the others. From your practice and from other sources, theory, practice, experience, others, what could be the cause? And is it that the latter stage where the recurrence is not being recorded, could it also be attributed to the fact that the high cost, maybe patients who experience recurrence later on pass on, and therefore they don't report. And that's why we are seeing a decline in the later stages, or any other factors. Thank you very much.
Okay, so looking at the recurrence, most of the studies that were carried out in an environment where affordability was most of the patients went on the medication. The pattern, there's no explanation to determine why the pattern is like that, but that's what have been reported in literature, and it seems that the pattern tends to be consistent from one study to the other. In terms of whether patient died, most often the study followed them up. So patient who dies maybe sometimes, most of them overall survival, so they'll be counted as the patient recurred. So because majority of them were overall survival, so the overall survival, so far as you died, maybe of any cause. So all patients that were after the 7 or 8 years, that they followed up with patients who were alive but didn't have any form of recurrence. Okay, so that's how the most of the go.
My question is my name is Naomi Nate. I'm with the Food and Drugs Authority. My question is to Farm Roger. In providing psychological support to cancer patients, how can pharmacists enhance their counseling skills, and in what cases do we have to refer cancer patients to maybe seek other psychological healthcare professionals? In what conditions do we need to refer? Thank you.
Thank you for the question. Indeed, the team is multidisciplinary. So psychologists are part of the team. So for patients who need psychological support, counseling, or any such intervention, usually they are quickly referred to be seen by the psychologist for the appropriate interventions to be made. We were at Tata Memorial Hospital. The psychologist was part of the team over there. Here in Kolebu, we have psychologists. The only thing is that here you have to invite them before they come, but at other centers, they are embedded in the team. Just last year, we had an issue. There was about 11-year-old young man who had osteosarcoma. He was playing football, he fell, and then got his leg broken. The parents took him to the bone setter, and they set the bone, but it was not getting healed. So later they sent him to a facility, received some care. It wasn't helping. The parent took him again to another bone setter. And then after some few months, they realized that it was becoming worse. So lastly, they went to another facility, which upon investigations being done, diagnosed osteosarcoma, was referred to Kolebu Teaching Hospital. Now, the part of the treatment was that the leg had to be amputated. But this child, 11-year-old, said that if his leg is amputated, he will kill himself. So that was some psychological problem, probably. We invited the psychologist in. They were counseled. The mother was okay, but the child refused amputation. Upon counseling upon counseling, the child said no. Later, we started with treatment. He received the first course of treatment, cisplatin-based treatment, experienced some side effects, and he decided that he will not take the cisplatin again. He will not go for chemotherapy also. We made all the necessary interventions. He was not willing. The parents were okay, but he wasn't willing. So he refused treatment. So after all the options were exhausted, they could not just be in the ward undertaking because they wanted to leave the hospital. They want to leave. So they signed the form that they've discharged themselves against medical advice. I have tried to call them back just to talk with them. Maybe there could be a change of mind, but my line, it wasn't going through. So as pharmacists, one of the things we can do, we can also go through psychosocial education. We can acquire some training in that field so that we can help, in some of those cases. So psychologists are there as members of the team, but we can also get trained in those fields if our interest is there, so that we can render those services to the patients. Thank you.
So I want to add that the treatment of cancer is evolving. So previously, for example, psychologists were not directly involved. But when it comes to, for example, the radiotherapy center, we have an in-house psychologist who provide psychological support to patients. And as Famroja indicated, it's a multidisciplinary team. So we have nurses as well who are navigation nurses. Has Enam left? We have dietitians, nurses as part of the multidisciplinary team. All are involved one way or the other in improving the psychosocial support of patients.
Okay. My name is Clement once again. My question goes to Famroja. With the multidisciplinary committee team that's been set up, it's important that the pharmacist in the hospital, the specialist pharmacist, is in the team. Is there a way to bring the community pharmacist as an extension of this team? These community pharmacists interact with these patients continuously. Let me say they have more interaction with these patients than the in-house hospital pharmacists, who may not have the time to continuously monitor these patients in real time. Every now and then he works from his house, he can go to the community pharmacy, but he may be living miles apart from the hospital. Is there a way for us to bring community pharmacists into this? Is college trying to give us some short courses for us to be able to augment the work of the specialist oncologist pharmacists, so then there can be continuity of care and the other comorbidities that are being also treated, we can also help in that regard, not only about the oncology, because we are mostly not specialist pharmacists, we are mostly general pharmacists. So that's my question. Thank you.
Thank you for the question. The multidisciplinary team, I think, is opened. As many as can play significant roles that will alleviate the burden for the patient, I think they are welcome. Importantly, as I mentioned, there were times when there were skills and knowledge that was required for improving the care of some of our patients. but they were not available in country, and therefore we had to resort to experts outside. So that is welcome. Regarding patients indeed staying in the community, usually when they are on the treatments, assigned protocols, they are always being monitored. The patients are always being monitored, and often as part of the counseling session before treatment is started, when we're counseling them, we inform them as to what to do when they see certain signs and symptoms or certain issues arising, what they should do. So that is what they usually do, whether to get in touch with the clinic, get in touch with the nurse or anything like that. So that is what is done. So they are educated on all the aspects as to how to respond to issues. Community pharmacists, indeed, you can educate yourself in this area. I don't know when the door will be open for you to already indirectly you are playing a role. All right. The only thing is that that role has to be played well, because we've had, for example, if I don't know whether it is relevant, we have situations where patients were going to the community pharmacy, receiving certain treatments, okay, which should have actually been referred earlier to the hospital so that appropriate diagnosis could be made for the right intervention to be made. But somehow, sometimes that is delayed. And cancers, they are aggressive. They don't wait for anybody. So the more there is delay, the more problem it will cause. But if the community pharmacist is equipped with requisite knowledge that no, what I am treating is not an ordinary fever. It is not just a migraine. It could be a malignancy. And therefore, after maybe one treatment, another, refer that patient quickly to the hospital for appropriate investigation and treatment. It will help improve the outcome of the treatment, because most cancers, the earlier they are detected, the better the prognosis. So that is one of the partnerships that we can build, so that community pharmacies will be able to refer, patients. Not only community pharmacies, even hospitals. There are hospitals that would have taken all the money from the patients, okay, drained them of every resource before they finally refer them for appropriate treatment. By the time they reach Konfanoche or Kolebu, all their monies have been spent. And now they have to receive treatment for cancer, which is very expensive. So OPAC is on the move to help educate community pharmacies, for example, so that appropriate referrals can be made in time.
I'm glad we have some community pharmacists here. I'm happy they are interested in oncology and they are seeking knowledge. It is very important that if you're in the community and you know some of these things, you can make appropriate intervention. I was in a community hospital, community pharmacy some time ago, and a lady came with a prescription. She's combed the whole of Kumasi and was not getting the medication. So when she brought it, I engaged her in conversation. And it was a cancer medication. She was pregnant, but did not inform the doctor. So when I engaged her in conversation, I noticed that she was pregnant. And it was, I think, 2 months pregnant. And if you get this medication and you take it, you are going to destroy the fetus. And she was also elderly. and the pregnancy was very precious to her. Do you get it? So with that interrogation, I told her to meet me in the hospital the next day. So I took the prescription. She met me. She sat in my office. I went to look for the consultant, discuss the prescription with. And the consultant told me, the lady never told him that she was pregnant. So he wanted to see this lady. Do you get it? And so I introduced them. Then they had a long chat. I hope you get it. So it's good we seek knowledge about these things, and then you make the appropriate intervention. The second one, another experience I had. There's a pharmacist who did a rotation in Kolebu and fortunately passed through oncology. And anytime they come, I take them through the medication, the side effects, and so on. So if you pass through my hand, you will know all the medications before you leave. And she happened to work in the NS chemist, I think around Circle. They wrote a cancer medication. Some of these things, you can't get them in community pharmacy. So she had roamed the whole of Accra. And then somebody said, go to Circle, NS chemist. And then she went. So they looked at it. And the lady said, this medication, you get it in Kolebu. Fortunately, she had my number and she called and asked whether this medication was there. I said, yes, we had it. This is it. So, there's a prescription from your place, but it has come to them and the patient has roamed about and is not getting it. And so directed the patient to our place. So you see the help the community pharmacy is giving this patient. There was a communication gap somewhere. It was given to her in the consulting room. It says, go to the pharmacy for it. But go to the pharmacy, and then she stepped outside. And then she started roaming about. You see, that was where the miscommunication came. But this lady, because had passed through the place and knew where she can get it, referred the lady back. Do you get it? So if you know some of these things, it will help the patient a lot. Thank you very much.
I just want to add something. When I talk about multidisciplinary team, it doesn't necessarily have to be those who sit at the table. Okay, it's anyone who play a role in the management of the patient. Patients after treatment comes to the community. Patient may have side effects, but you have to also be knowledgeable to pick up or manage the patient appropriately. Because if you don't have the knowledge and you keep on to it, then it's going to make it worse. So sometimes we are a team here. That's why you have colleagues. If a patient who you know probably so the patient comes, I receive chemo, I'm having ABC symptoms. It's best even if you don't have ideas, sometimes just how to learn is maybe you contact your other colleague, or I have a patient like this who came to me. What should I do? Oh, do ABCD. So that's where the learning curve starts from, because sometimes it's difficult for you to go back to the book to go and read. And some of the pharmacy maybe may store one or two medications that may be used in oncology. It's not just about prescribing, like selling it out. You should know how it works. So these are how you build up the multidisciplinary team.
So Stephen Odum wants to ask a question. Is he online? Oh, sorry. So can you unmute and then speak? Stephen. So yeah, all right. So thank you very much for the questions. We are waiting for him. If he comes online, then would yeah. I know. I also wanted to hear from him. Okay, so thank you very much for the questions, and then I believe the presenters have also answered your questions duly. I also want to just mention a couple of things before we finally close the meeting. So like I mentioned, AstraZeneca, we are in the space of oncology, and there are a lot of things that the efficacious medications. So it's an advocacy I'm giving out to our pharmacists. Our patients trust us when they come to the pharmacy with every information you give them. And currently, as AstraZeneca, we are facing a lot of parallel importations of our medications that you are aware of. I know you are aware of the Zoladex. And so these are some of the careful pointers you should be looking out for. So currently, the Zoladex that comes into the market is an English pack. It goes through FDA, goes through all the necessary process. And the PIs have the Turkish language on it. So please be on the lookout for such brands. And like he said, if you are at the community pharmacy and you find out something like that, you have to point out to the necessary personnel around that this is not what you cannot guarantee the safety of this particular brand. So as much as Zoladex is not a cold chain drug, it still has to be stored under 25 degrees Celsius. And so you can imagine the temperature we have in Ghana already. And so we have distributors who actually bring it in through the right channels. So if anybody is bringing it in their suitcases or in their, can imagine how the drug becomes at the end of the day. Yes, so that is one of the information I wanted to give out. And I'm very happy that there are heads of pharmacists here who would ensure. I see 37, I see UGMC, I see Kolebu, I know I've realized Dusty. All of these places, you have the means to stop some of these occurrences. Then the second part is the targeted therapy that Dr. Ajimine and Farm Godfred also mentioned. So in AstraZeneca, we have targeted therapy medications. He mentioned fulvestrant, which is Faslodex. It's a medication for postmenopausal hormone receptor positive breast cancer patients. So he talked about the luminal A and B, and then HER2 negative. Sorry, so we are in the space of estrogen receptor positive, basically hormone receptor positive breast cancer. So anything that, so you have the Zoladex in premenopausal women for ovarian function suppression, and then you have Faslodex for postmenopausal women, hormone receptor positive breast cancer. And one of the things he also mentioned was that what are some of the things that we are doing to make sure that at least price is not a burden. So another thing that we are doing is that we have a patient access program for the Faslodex. So when a patient buys one, they get 2 of the loading dose for free. So that is something that we are doing as AstraZeneca to help with the burden of costs for these patients. So for those in UGMC, those who are actually doing oncology in their centers, they are aware of these interventions that we are bringing in. But it's worthy for you to also note that these are some of the things we are trying to do to help patient care as well. So again, with the MDT, like he mentioned, let's all try, and when we find out that a patient has come to the community pharmacy, a patient has come to any pharmacy where there is no oncology going on, the Kolebu Hospital Radiotherapy Unit, they are a call away. Now you know from Godfred. So if anything, you can just call him and let them know. There are also nurse navigators in Kolebu that also help with some of these things. Can just call them and then they'll guide you on that as well. So on that note, I appreciate the meeting very well, and I'm grateful for all of you for coming. And I'll just take my country manager is here. She wants to thank, she says I've said everything, so we would invite her up so that she can say something. Thank you, Sharon.
Thank you, Sharon. But I think she covered everything. In fact, everything I wanted to say, she's managed to cover it. But first of all, I'd like to apologize once again. I think we advertised for 4 p.m. and we ended up starting at 5. I thought it wasn't fair on those of you who came physically to wait before the virtual attendees came online. So apologies once again. AstraZeneca, we are not usually like this. This is just a one-off, and we promise not to repeat it. So thank you very much, Dr. Mervyn Ajimine, and Farm Dr. Godfrey J, and then Farm Ahiable. I think I got them correct, right? Yes. Your presentations were very insightful, especially for me. I think I've been in AstraZeneca for 12 years, but I think I did almost a decade of cardiovascular. But in this role, I have to actually wear a lot of hats. So I'm learning. I'm actually a rookie in oncology. So I appreciated the basics of oncology, and I'm still learning. In fact, I took some notes, but I think I need more lessons. So you'll be seeing me in your consultation room. Yes, so thank you very much to our speakers. As I said, the presentations were very insightful, and also to our attendees, both physically and virtually. Thank you for your valuable contributions. This will not be a one-off. We believe that pharmacists form a very important part of the patient journey, and we need to empower ourselves so that we can manage these patients when we come across them. So thank you very much for coming. And secondly, just to probably stress on what Sharon was saying, as a company, we are very much dedicated in putting the patient first. And in Ghana, unfortunately, I think government has not been too receptive. I hope this present one will be different, but we are committed to putting the patient first. One, we believe in health equity. So no matter how expensive the drug is, I believe if we are able to have dialogue with government, then we can do something so that it's accessible to the patient. Because what's the point if we, do all this R&D, spend a lot of money, then we come up with fantastic molecules. I'm sure Dr. Mervyn Ajima knows some of them, life-changing oncology products, but patient cannot access it. I think it defeats the purpose. Oftentimes on our side, we do discounts, but then most of patients still cannot afford it. So if government was meeting us halfway, I believe that by now, even our Zoladex, which is indicated in prostate cancer and breast cancer, should have been on the national health insurance. So I bring this in because you are professionals. You sit in meetings that we may not be in. You find yourself with policy makers. Maybe you can also chip it in. We are also pushing on our side. We are committed to ensuring that our medications are accessible to the majority of our patients. So that is our commitment. So let's keep pushing. Let's keep helping these patients, and I'm sure that there are better days ahead. So thank you very much.
Thank you very much. So our chairman will close everything with what we have done so far. Mubri Ebwa, please, they need to see you on stage.
Thank you very much. I'm glad we have a lot of pharmacists here. And I'm happy you are going to tell other colleagues of yours to take that kind of phobia about cytotoxics away. In fact, I don't know where that is coming from, but pharmacists are afraid of cytotoxics. And so we have very few pharmacists in oncology. I want a lot of pharmacists to enter into that space. Again, it is my prayer that these newer medications will find them on the health insurance list. 2 years ago, I attended a conference in South Africa, and it looks like almost everything is on health insurance. And therefore, the doctors are very confident in prescribing. Therefore, the patients do not fear to go to the hospital, and they do not fear to buy expensive drugs anyway, because everything was on health insurance. And so when the lectures were going on, we tried this, then we moved on to another, and then it helps also in research. In fact, I was so excited. So let us see how we can advocate for all these kind of medicines to go onto health insurance. Then it will be easier for us to use them. I want pharmacists also to join in the public health education of our community. We shouldn't leave it for only nurses or doctors to do that. We have a role to play in the public education, especially in cancer treatment. I gave a lecture in my church concerning breasts, even demonstrated how to do breast self-examination. And I was surprised. The reception I got, is it? So please, so let us be advocates of these things. Let's educate our people. Very important. This is. Then I have a lot of nurses here. We should not leave them alone. I do a lot of teaching, and I teach nurses also. I went for a conference in Kenya, and I was taught how to do aseptic preparation. When I came, the following Friday was, and then I organized and we taught them. But they do a lot of inside there. Do you get it? You notice where nurses do administration. When you go, look at the wall, you notice that there are certain things on the wall. It is because of the way they handle the syringe and the needle. Do you get it? They have to be taught. So, my dear nurses, I'm happy you are here, and I'm sure you have learned a lot. Thank you very much for backing us. AstraZeneca, in fact, I don't know how to thank you. OPAG, we have been missing for a long time, and I'm happy you are bringing us to life. And I'm sure, like your country manager said, it will not be a one-off thing. Let us come together. I think I'm going to have a special relationship with your country manager, a very special relationship, so that OPAC will continue this kind of education. Thank you very much.
So please, the program has ended. We are ready for dinner. Thank you all for coming, and God bless us all.